Hello there, my name is Declan Costello and I'm an ear, nose and throat surgeon and I specialise in voice disorders. I'm going to talk to you for the next little while about the anatomy of the voice and how it works, and in subsequent lectures I'm going to talk to you about ways in which the voice can go wrong and also about hormones and their effect on the voice. So if I may, I'm going to bring up my presentation here for you and we can watch some slides. Here we go. Great. So hopefully you can see me, you can see my slides, and let's get started. I'm going to start by introducing you to Saint Blaise, who is the patron saint of throats. Saint Blaise has his Saint's Day on the 4th of February every year. And if you are singing at Westminster Cathedral at any stage on the 4th of February, you will have your throat blessed by a priest who will come up to you with a pair of crossed candles, lit candles, and come up to your throat and bless it. So potentially a bit hazardous. And St. Blaise became the patron saint of throats when he reputedly removed a fishbone from the throat of a young child. And this statue you see in front of you is in the lobby of the Royal National Throat, Nose and Ear Hospital in King's Cross. In fact, the Royal National Throat, Nose and Ear Hospital is just about to close down and move to UCL in 2020. And the statue, I gather, is going to be moving with it. So let me tell you a little bit about what I do and about laryngologists. ENT surgeons all specialties of doctor now really subdivide themselves into very niche categories. And within the ENT of ear, nose and throat surgery, I have a subspecialist interest in just the T in the throat and voice disorders. And so I'm a laryngologist. I study the larynx. Voice clinics in hospitals are specifically set up very often with the needs of professional voice users in mind. And with their vocal problems. And a lot of laryngologists have an interest and quite a significant insight into performers and the demands that are placed on them. My own background is of music. In fact, I started studying in 1991. Gosh, that's a long time ago. I studied music at St John's College, Cambridge, after I'd left school. And when I was at school, I didn't really have any professional aspirations to singing, but it looked like I might be able to get a choral scholarship to this place, to St John's, Cambridge. And I did that for 3 years. I studied music there as a choral scholar. Had a fantastic time, but halfway through my music degree realized that I wanted to study medicine after all. And so I started from scratch. You can imagine how thrilled my parents were at the prospect of me leaving university in 1994 and then announcing I was going to do another 5 years of study. So 1994 to 99, I studied medicine at Imperial College in London. And while I was at medical school, I did some depping, I did some singing around the place to keep some money rolling in. So let's talk then about musical instruments and how the larynx, how the voice is like a musical instrument. Any musical instrument requires 3 fundamental things. And if you think about the violin for a second, the violin has 3 core components. One is something to give energy to the whole system. In other words, to make the whole thing move and vibrate. And in a violin, obviously, that's the bow. And the arm, the player's arm moving the bow. The second thing that's needed is something to vibrate and produce sound, and clearly in a violin that's the violin strings. And then the third thing you need is something to modify and make the sound more interesting and rich, and in a violin that is the body. So if you think then about the voice and how does that carry forward to the voice, well, the energy source, the thing that drives the whole thing into motion in the voice is the lungs, which drives air through the vocal folds, and the vocal folds vibrate to produce sound. Now, you're going to see quite a number of these sort of photographs of the larynx and the vocal cords as we go through this talk. So I really just want to familiarize you with how this photograph is taken, and so that you can orientate yourself to it. So this photo is taken, if you imagine that I have a mirror at 45 degrees in the back of my throat. So I've got my tongue out and you've got a mirror on the end of a stick to look at the back of my throat. So as you look directly in, you're then looking downwards using the angled mirror. So looking at this photograph, this is the right vocal fold, this is the left vocal fold, this is the back of the throat, and this is the front. Okay, this is the right side and this is the left, because it's as if you've got a mirror looking straight in and down. Now, we'll talk about the difference between vocal cords and vocal folds in a minute. There isn't really any difference, is the simple answer. So you can see here that if that's the right vocal fold and that's the left vocal fold, they're apart. And they're apart when you're breathing. And this point at the front is called the anterior commissure, and the vocal cords are fixed at that point. And it's only at the back, it's only at the top of this photograph that the vocal cords can move. So at the back, they move apart to breathe, and they come together to produce sound. And you'll see lots of this as we go along, so don't worry if you haven't quite got the hang of that yet. So the vocal cords, vocal folds are the things that come together to produce sound. And what essentially happens is that the vocal cords come together, the air comes from underneath, comes from the lungs, and in this photograph, the lungs are off in that direction. The air pushes the vocal cords apart, and then they come back together again. Now, that produces a buzzing sound, and we'll talk about that in a moment. And then what happens is that you have a resonating chamber. You know, you have the body of the violin, and you've now got the resonating chamber of the voice. And in this scenario, the resonating chamber, well, it's the back of the throat, the pharynx, the shape of the inside of the mouth, the oral cavity, the nose to a certain extent, chest a little bit, I suppose, sinuses, but perhaps not quite so much. It's largely, the resonance largely actually is about modifying the shape of the back of the throat. So let's look at this again. Again, this is the right vocal fold, left vocal fold. This is looking at it from directly above. So we're looking effectively vertically downwards towards the feet in this photograph. When we're going to look at them in a slightly different way now. So these two images at the bottom are taken in coronal sections. So these are slices through the neck in that direction. So you're looking face on at a slice in this direction now. Now you can see why, in fact, they're called vocal folds rather than vocal cords. So if these here, this is the right vocal fold and this is the left vocal fold, and you can see that they're actually really just infoldings of the airway. So if the lungs are down here and the back of the throat is up here, these are infoldings of the airway. This is the right vocal fold, this is the left vocal fold. They're just infoldings of the airway. So they're not cords in the sense that they're like rubber bands hanging in space. They are infoldings of the tube of the airway. If those are the true vocal folds, then these actually are the false vocal folds, and we can talk about false vocal folds a bit later. So, thinking about pitch for a moment, when you ting a tuning fork, and I think I may even have one here, when you ting a tuning fork, the tines of the tuning fork of an A440, for example, the tines of the tuning fork are vibrating 440 times a second. Hang on, let me see if I've got one here. No, I can't find it. Anyway, it's vanished somewhere. But anyway, so when you ting a tuning fork, the tuning fork is vibrating 440 times a second. So each one of the tines of the tuning fork is going back and forth 440 times each second. And the same is true of the voice. When you sing an A above middle C, which is A440, the vocal folds are moving apart and together 440 times a second. And when you go up an octave, you double the frequency. So soprano top A is 880 hertz, 880 times per second. The vocal cords are moving apart and together. They do that 880 times a second. The Allegri Miserere, sung around the world in cathedrals and churches on Ash Wednesday, involves the treble or the soprano singing a top C, which is about 1,024 hertz, 1,024 vibrations per second. So you can see that this whole system really needs to work in a very pliable and smooth and supple way to allow that sort of very rapid movement to happen. How do the vocal folds move that quickly? Well, there isn't a muscle that is vibrating 1,000 times a second. No muscle can move quite that fast. So what happens is that the vocal folds start close together. Now, you saw the photographs a second ago, the vocal folds apart. And what happens when you start to produce sound is that you bring the vocal folds together, and then the pressure from the lungs from underneath pushes the vocal cords apart just a tiny bit, just a millimetre or two, and a puff of air escapes, and then a fraction of a second later they snap shut again. So they're moving apart and together just a millimetre or two at a time, and each puff of air, whether it's at 220 hertz, 440 hertz, 880 hertz, those puffs of air are transmitted to your ear, and that is perceived as sound, and the different frequency of vibration determines the pitch that you're hearing. And the fact that the vocal folds move apart and then snap shut again, the snapping shut again happens partly because of elasticity, partly because they just snap shut because they're flexible and elastic and they come back together, and partly because of an effect in physics called the Bernoulli effect, which means that if air passes between two spaces, between two surfaces, they will tend to be pulled back together again. So it's the Bernoulli effect and also some elasticity of the vocal folds. Now, this is a video demonstrating roughly the thing that I've just outlined. You can see that the vocal folds are moving apart and together here, and in a minute this video is going to zoom around and show you the vocal folds moving in slow motion. Clearly this is in slow motion because they look like they're only moving about once a second in this video, but in practice they're moving much more frequently than that. Here we go again with that same video. Now, the thing that's worth noting here is that rather than the vocal cords moving apart and together in a block, they're actually moving in a sort of gliding sort of way. So air from underneath pushes the vocal folds apart at their lower surface, and then they move apart at their upper surface, and then the lower part of the vocal fold comes together, and then the upper part of the vocal folds comes together. So they're moving in a very sort of gliding, smooth, pliable sort of way. And in order for that to happen, the vocal folds you have to understand a little bit about the structure of the vocal folds to get to grips with why that pliability happens. Now, there are several different layers of the vocal folds. The surface layer, the area that you see when you look down with a light, is the epithelium. It's this one here, the dark yellow epithelium, which is the very surface-most layer. Immediately under that, this pale yellow is known as Ranke's space, also known as superficial lamina propria. Now, the superficial lamina propria, I will keep going on about this in the course of this lecture and the next ones, because it is absolutely critical to understanding how the pliability of the vocal cords works. So that's the superficial lamina propria. Deep to that, in this photograph you see it in red, is the vocal ligament, which is also known as the intermediate and deep lamina propria. And then in this diagram in blue is the muscle, and the muscle within the vocal fold is known as thyroarytenoid or vocalis. Now, in order for that pliable, smooth action to happen, the superficial lamina propria, Ranke's space, is absolutely critical. If you lose any of that space, if you get scarring, for example, and I'll tell you about that later, but if you get scarring in the larynx, you lose the superficial lamina propria and you lose the pliability, and that is an absolute disaster for voice production. So if we just look at this video for a second, this is a video taken in the clinic, and these are the kinds of images that we're getting when we're looking at the larynx in our day-to-day practice when we're examining singers. Now, what I'm saying here, let me just move this photograph of me. What we're seeing here is the vocal folds moving apart and together. They're moving 150 times a second, 150 hertz, which is somewhere below the A below middle C. And this, you can see as we look at this moving in slow motion, it creates what's known as a mucosal wave. And you can see why, because the mucosa, which is the lining of the vocal cord, appears to be doing a sort of belly dance, a sort of a wave. And this technique of looking at the vocal folds moving in slow motion is known as stroboscopy. And stroboscopy is a technique that laryngologists use to get a good look at the vocal cords moving in slow motion. And it's absolutely critical that we use stroboscopy for looking at larynxes in singers, because it gives us very, very detailed information about the pliability and the suppleness of the vocal cords. If we weren't looking at the vocal cords moving in slow motion here, they would just appear as a blur. If they're moving 150 times a second, your eye is never going to be able to see that happening. So this stroboscopy technique gives the illusion of slow motion and allows us to see whether there's any scarring there. So one of the top tips to take away from this lecture is that if you are ever needing to see somebody for a discussion about your voice and problems you're having with your voice, it is imperative that you insist on having a stroboscopic examination to get detailed views of the vocal folds. If you don't have stroboscopy, you will not get the answer you need. So we've talked there about the vocal folds, which are the part of the larynx that produces the sound. If you were to take the vocal folds out of the neck and blow air through them, and people have done this, then the vocal folds themselves just produce a very uninteresting buzzing sound. And my larynx, my vocal cords, will be indistinguishable from anybody else's, really. It is the resonating chambers of the rest of the vocal tract that give a voice its characteristic qualities. And the resonators are really the pharynx, which is the area of the throat behind and above the vocal cords, the oral cavity, so the shape of the mouth itself, the nasal cavity bits. You'll have to excuse the noises going on in the background. That's my daughter yelling. There you go, apologies. The larynx itself, there are some sort of nooks and crannies within the larynx that produce resonance as well. Sinuses and chest and skull tend not to contribute all that much to resonance, actually, although intuitively you would have thought they would. And it is the size and shape of all of those resonators that gives a voice its characteristic qualities. When you hear this buzzing noise that the vocal folds produce when they're taken out, the vocal folds are producing a pitch, and you can hear one pitch that they're making. But what you don't hear is a lot of harmonics above that. Overtones and harmonics. All your brain consciously hears is a single tone. And when you change the shape of your pharynx, you can accentuate different ones of those overtones and harmonics to change the quality and change the timbre of the sound that your voice is producing. So, for example, if I sing a series of vowels, if I go I, you, are, because I'm singing just one note across those 5 vowels, the vocal folds are vibrating at exactly the same pitch all the way across. So the vocal folds are not changing at all. The only thing that is changing is the shape of my pharynx and the shape of my oral cavity, the shape of my mouth. And by doing that, I'm accentuating different harmonics and different overtones in the sound, and that changes the quality of the sound. In other words, it changes the vowel I'm producing. And by altering that, you change very fundamentally the timbre and quality and colour of the voice as you go along. Now let's just have a look at this graph. This is a graph produced by getting a singer to sing one note into a computer, and the computer has then broken up that note into all of its different overtones and harmonics. So if you have a look at this, so down here is one big peak. So this is just, so up here is the loudness, and along the x-axis is the frequency. So you can see that if this singer is just singing one note, they're actually not really just producing one pitch. There are lots and lots of pitches being produced on this graph, but you're just hearing one. So down here, there's a big peak around 500 hertz. So they're singing at about 500 hertz. And then there's all of these other peaks as you go along. And there is one particular peak that is louder than all of the others, and that's around 3 kilohertz, and it's called the singer's formant. And singers in the Western classical tradition have learned to accentuate this one particular harmonic frequency, and classical singers in particular do it by using a low larynx. So there's quite a long space between the larynx and the lips, and that means that with this big space that you've got, you can produce quite a lot of resonant frequencies. And this one particular frequency that classical singers produce gives a voice its brightness and spin. And it's this quality, it's this singer's formant that allows for a classical singer to be heard over a symphony orchestra, for example, and they're not reliant purely on decibels. Now, that singer's formant you would hear as a brightness in the voice, and different singers and singing teachers call it different things. You can call it laser, ping, spin, blade, brightness, energy, drive, whatever you want to call it, but that kind of quality that really allows the classical singer's voice to carry. So I hope that's reasonably clear. Singer's formant is a very important thing. So this is just a video illustrating what happens when you produce a vowel. This is somebody saying, hello, let's go back to this one, saying I. I. So on the R, if you do it yourself, you'll be aware that the R is a rather tongue-backed sound. I. And for the E, the tongue comes forward, and you can see that on this video. I. The different vowels are produced by holding the tongue and the lips and the pharynx in different positions to accentuate different harmonics. So that is just a little bit about the vocal resonators. How do you change notes when you're singing? Well, if you think for a second about a rubber band, the pitch that you get when you twang a rubber band, the pitch that you get depends on a couple of things. It depends on the fatness of the rubber band, and the fatter a rubber band you have, the lower the pitch. And it also depends on the tension. So if you stretch that rubber band quite tight, the pitch goes up. So men who have denser and fatter vocal folds have lower voices, and these dense, fat vocal folds typically come about under the influence of testosterone during adolescence. So for adolescent boys whose voices are breaking, you get this sudden surge of testosterone, and the larynx suddenly changes shape, the cartilages change shape and size, and the vocal folds themselves become thicker. When you raise the pitch of the voice, and don't worry too much about this diagram, but essentially there's a series of sort of levers and pulleys and things, and when you stretch the vocal folds, the pitch goes up, and when the vocal folds are short and fat, the pitch goes down. And we'll see a little bit about the cricothyroid visor in a minute. So this is just an illustration of how the vocal folds move to raise the pitch. Let's look at this one, I think, bottom right. Look at the bottom right animation here. This is an animation taken as if you're looking from behind the patient's head and looking kind of down in that direction. So that's the front of the larynx and that's the back of the larynx. And you can see that as the thyroid cartilage moves, it's stretching the vocal folds. This will become a little bit clearer when we have a look at some images in just a moment. So we haven't, yeah, that's my daughter again. So we haven't even mentioned actually up to this point what the larynx is for. Well, I hate to rain on your parade, so to speak, but it's really not fundamentally for speaking or singing. And that the speaking and singing aspect of using the larynx is very much a sort of secondary advantage that we have developed, but not a fundamental importance. The primary thing, of course, is that it's for protection of the airway. The larynx is a sphincter. It's a set of muscles that closes tight shut to protect the airway when you're swallowing. It's obviously a tube also, so that air can get in and out. And we'll see a video of this. This is a photograph of somebody swallowing. Now, the other thing, of course, that the larynx does is to allow you to cough. And a cough happens when you bring the vocal cords together and then you forcibly push them apart with a great deal of energy, with a blast of air from the lungs. And that is an extremely important function of the larynx, because you want to be able to raise the pressure in your chest and then expel foreign material. And the expelling of foreign material can happen if you've got a chest infection, for example, or if you've inhaled a crumb or whatever else. And then the final thing to say is that the larynx is very useful when you are straining. And when you strain, you take a deep breath in, you close the vocal cords, and then you try and force air up through the vocal cords, but you can't get any air out. So what happens then is that the pressure builds up in your chest, and that pressure is then pushed downwards towards your abdomen. So you can strain, and that raises the pressure in your abdomen. And that's useful in two situations, principally. Firstly, straining at the stool, as it were, straining when you're on the toilet to push stuff downwards and out the back end. And then the second situation is when you're straining in childbirth. You do need to strain to raise the pressure in the abdomen to push stuff downwards, in other words, to push the baby down and out. So this is a video of somebody swallowing. Here comes this person swallowing what looks a bit like an oyster to me. So they're chewing, chewing, chewing. The food bolus, the lump of food, is pushed up to the back of the mouth, over the back of the tongue, and down into the esophagus. So I'm going to play that video again, and I'll orientate you just before we start. So food bolus, tongue, here, and it's going to go into the mouth. This is the soft palate, the dangly bit with the uvula on the back of it, and this is it touching the back wall of the pharynx. So as we're looking, this is a slice obviously in this direction now. So this is the epiglottis, which is the cartilage that is going to tip over in a minute and prevent the food and drink from going down into the airway. And this here is the larynx. So at the back is the esophagus, the food pipe, and at the front is the larynx, and the trachea is off in that direction. So let's just watch this play. So you're going to see the food go in, you're going to see the tongue push the food bolus to the back of the throat, the soft palate closes off the back of the nose, food comes over, here comes the epiglottis tipping back to push the food backwards towards the esophagus, and nothing gets into the airway. Nothing is getting into the trachea at all. Let me play that for you again, just one more time. Food in, the bolus is manipulated mouth, pushed to the back of the throat, and the soft palate closes. The food bolus then is pushed downwards, epiglottis tilts, the whole larynx rises, and the airway is clear of debris, of any food and drink, and it all goes down the esophagus. And that motion of squeezing the food downwards is called peristalsis. Now, that series of maneuvers, that series of movements from the food getting into the mouth, being manipulated, pushed to the back of the throat, and all of those other things happen in a very, very precisely timed sequence. And if any single thing goes wrong at any stage along that path, that can cause food and drink to go down into the larynx and into the lungs, and is potentially really absolutely catastrophic for the patient, because food and drink goes down into the lungs and causes pneumonia. Now, you can imagine that if there is a neurological problem, so for example, if the patient has had a stroke, that can knock off all sorts of stuff in terms of tongue movement, vocal cord movement, all of the various muscles moving. And that's a real disaster. And that's why patients who've had a stroke often end up having significant problems with swallowing, and can end up with pneumonia. And if food and drink go down into the lungs, that's called aspiration pneumonia. And that really is potentially very, very bad news indeed. So neurological things can have a profound effect on swallowing in the longer term. So there is some of this anatomy that you can actually feel on yourself, and you can do it now. It's very easy to do. If you just reach up under your jawline, just under your jaw, it feels a bit soft and squidgy, and then if you feel down a bit further, you'll feel a firm swelling, a firm mass on either side. Bear with me just a second. Bear with me just 1 second. I'm going to. So you can feel the hyoid. The hyoid bone is this very firm swelling that you're feeling here, and that's illustrated in white on this diagram. If you then, and the hyoid bone, incidentally, is a bone of the larynx. It's the only. This is a pub quiz question. The hyoid bone is the only bone in the body not attached to another bone or not articulating with another bone. Now, if you then take your finger and run your finger down the midline, then in men, the first thing you will get to is the thyroid cartilage. Now, the thyroid cartilage is shaped a bit like that. It's shaped like a shield. and in men, the thyroid cartilage is very easy to feel because you can feel the Adam's apple. In some women, you can feel the thyroid cartilage as well. And then if you run your finger down a bit further, the next prominence you'll get to is called the cricoid cartilage. Now, you can probably see on my screen a few of these landmarks already. That is my thyroid cartilage. And as I run my finger down, my cricoid is just there. Now you can see that between the thyroid cartilage and the cricoid cartilage, there is a dimple, and that dimple is called the thyrohyoid membrane. Anatomists are really pretty unimaginative people, and whenever there are two things attached to each other, they just put the two names together. It's a bit like German. So you put the two things together so that the membrane between the thyroid and the cricoid is called the cricothyroid membrane. And the cricothyroid membrane is very useful because it's an easy landmark to feel, and we can use that landmark sometimes if you need to do an emergency airway. So this is where you're stuck in a steak restaurant on a Friday night, and somebody's choking on their fillet steak, and you can't get it out with a Heimlich maneuver or whatever. That's the point at which you're going to get your steak knife and make a hole in the front of the neck, and allow them to you can bypass it if the steak is stuck up here. So that's the hyoid bone, the thyroid cartilage, the cricoid cartilage, and then further down in the neck, just above the level of the sternum of the breastbone, is the thyroid gland. Now you probably won't feel the thyroid gland. It's sometimes palpable. You can sometimes feel it in women, but usually it's not palpable, and it's not normally a big problem, even if you can feel it. So I'm going to talk for a bit about the nerve supply of the larynx, which might seem a little bit nerdy. By the nerve supply, I mean the nerves that go to the larynx and make the muscles move. Every muscle needs to have a nerve to give it instructions as to when to move. And the nerve supply of the larynx is interesting. Now, in the nerve to the larynx is called the recurrent laryngeal nerve. On each side, there is a recurrent laryngeal nerve. There's one for the left and there's one for the right. Now, if you look at, this is the diagram of what happens on the left side. So here's the brain, and the nerve is going to come all the way down here, and the nerve to the larynx actually hitchhikes with this one called the vagus nerve, and it runs down in the neck, down around, and then goes into the chest, and the nerve loops around the aorta, up and adjacent to the trachea, adjacent to the windpipe, and then goes up into the larynx. So this recurrent laryngeal nerve has a very long path, and there's quite a lot of opportunity therefore for it to be damaged or injured, or for things to grow into it and to cause problems. So the recurrent laryngeal nerve is the most important of the nerves to the larynx. There's one on each side. The recurrent laryngeal nerve is responsible for moving the vocal cord on that side to the midline or apart. Now, I mention this because you can see down here, and we were talking about the thyroid gland being right next to your trachea, right next to your windpipe a second ago, and occasionally the recurrent laryngeal nerve can be damaged in the course of thyroid surgery. And if that happens, that means that one of the vocal cords fails to move. So you get a paralysis of a vocal cord, which is, for a singer, a bit of a catastrophe. And we'll come back to that as we go along. Now, there is another nerve that goes to the larynx, again, another one on each side, and that's called the superior laryngeal nerve. So this is the superior laryngeal nerve here. Again, it starts in the brain, moves its way down through the neck, and this one just goes directly to the larynx and into the muscles around the larynx. Now, this superior laryngeal nerve is responsible for changing the pitch of the voice. Now, that is therefore absolutely critical for singers, that the superior laryngeal nerve is working well, and obviously the recurrent laryngeal nerve as well. If you lose the superior laryngeal nerve, you lose the ability to fine-tune the pitch of your voice, and that is very, very problematic for a singer. Now, just thinking about the thyroid surgery for a minute, the recurrent laryngeal nerve is not very often damaged in thyroid surgery because most thyroid surgeons are very well aware of the anatomy of it, and they do their very best to avoid it, although sometimes the nerve can be damaged in the course of thyroid surgery. But the superior thyroid nerve, the superior laryngeal nerve, I should say, is much more difficult to identify and much more difficult to protect in the course of thyroid surgery. So the punchline from this really is that if you do need to have thyroid surgery, and it might happen, there are various people. Toby Spence, for example, is a very famous tenor who had to have thyroid surgery. And if you are going to have thyroid surgery, the trick is to go to somebody who has operated on hundreds or thousands of thyroids in the past, and you ask them, what is your nerve injury rate? All thyroid surgeons are going occasionally to cause problems with laryngeal nerves. If they have a high injury rate, then that is a problem. Well, now let's look at this. So this is the giraffe. The giraffe, bizarrely, has the same kind of arrangement as in the human. The nerve to the larynx starts in the brain. It goes all the way down in the neck into the chest, loops up, goes all the way back up into the larynx. It's absolutely bonkers. They've got this hugely long recurrent laryngeal nerve. But that's the way it was designed. So, I said that a recurrent laryngeal nerve results in a paralysis of one of the vocal folds. This is a normal larynx. You can see the vocal folds come together to produce sound, and they move apart when the patient takes a breath, and they're moving symmetrically. Yeah? So I think we're happy with that. That's them coming together. That's a stroboscopic view, and the vocal folds move apart when the patient's breathing. Great. Look at this one instead now. So this is a patient with a recurrent laryngeal nerve injury with a vocal cord paralysis on the left side. You can see that this side is just not moving at all. This side is moving fine. The left side is really not moving at all. Now, one of the consequences of that is that the patient is never quite getting the vocal cords to close completely. You can see here that there is always a bit of a gap between the vocal cords, and that results in air escape, and the air escape you will perceive as a breathy quality to the voice. So a unilateral or one-sided vocal cord paralysis can be caused by thyroid surgery and gives a breathy quality to the voice. And for a singer, that is really pretty catastrophic. And we'll see some more of that in subsequent lectures. You are all singers, you all know this stuff already, but just to remind you that there are numerous mucus-producing glands in the larynx, not on the vocal cords themselves actually, but certainly around the vocal cords. And the more water you have and the less caffeine you have, the thinner and more watery and the more soft the mucus is. If you have a dry day, if you have 3 cups of coffee and no water at all, your mucus will be dry and thick and sticky, and that will stick to your throat and really irritate and make you want to clear your throat. We're swallowing this stuff absolutely constantly, and my recommendation to singers that I see is that you're drinking 2 or 3 litres of water a day, 4 to 6 pints of water a day, which is an awful lot, but it's worth it in the pursuit of trying to keep the voice healthy. So up to this point so far, we have had the thing that is producing sound, the vocal folds. We've had the resonators, so the pharynx itself. What's left? Well, just the lungs, the thing that is providing the energy source for the voice. What's the function of the lungs? Well, I hate to break it to you again, but the function of the lungs is not primarily to do with voice. The most important thing, obviously, that the lungs do is to allow oxygen into the bloodstream and to take carbon dioxide away. There is also a vein filtering function of the lungs as well. And interestingly, they're an interface with the environment. When you take a deep breath, dust, bacteria, viruses, all sorts of stuff are getting into your lungs. And it's often there that the immune system first meets these foreign things and decides whether they're friend or foe. And the immune system can then start to set up immune reactions to things that it deems are not going to be friendly to it. So this is really just a schematic diagram looking at the structure of the lung. So you can see this is the trachea, the windpipe as it comes down. It then divides into 2 main bronchi, which divides further, divides further, divides further. So there are multiple divisions of these tubes ending in these little sacs at the end called alveoli. This is a wax cast. My father is a chest physician, and this is a wax cast that he had in his office for years. So a cadaver, a deceased person, had wax poured into the tubes of their lungs, and you can see this multiple branching. This is really only a very small proportion of the multiple branches of the airways. This is a slide really just to illustrate the fact that the whole airway is one thing. So nose and mouth are connected to pharynx, connected to larynx, trachea, and all the rest of them. So and to all of the rest of the airway. And it's not uncommon for a process that affects one part of the airway to affect another part. So, for example, patients who have asthma may also have nasal polyps or may have allergic problems with their nose. And the two things go hand in hand, and they're quite similar processes. And if you treat the nose in somebody who has asthma, then the chest gets better. And if you treat the chest, then the nose gets better. Best still, of course, is to treat both, and then they both get better. So the function of the lungs is primarily gas exchange. In other words, for oxygen to get in and for carbon dioxide to get out. And in the alveoli, so here we are, the air has come through this tube here, and the air is sitting in this sac. And what happens is that the oxygen then goes through this tiny thin layer of cells into the outside space, and then the blue blood that's coming from the heart that hasn't got any oxygen in it gets oxygen passed into it, and then in red here, this oxygenated blood can then go back to the heart to be pumped around the body. So oxygen is diffusing, it's passing passively through the lining of the alveolus and into the bloodstream. There are many alveoli, and you have a huge surface area of the alveoli in the lungs. Just thinking for a second about the actual mechanics of taking a breath. When you take a breath, the ribs move out and apart, and the diaphragm moves down. Again, sorry about the shouting off. The ribs move out and apart, and the diaphragm moves down. Raising the shoulders in the course of doing this achieves absolutely nothing. You'll see young singers and choristers frantically raising their shoulders to try to get some breath in. That does nothing, and in fact, I think is probably counterproductive, because all it does is to introduce tension into the neck, and that can have knock-on effects of its own. This is a graph just illustrating what happens when you're breathing. The total, as you're sitting now, breathing quietly, you're breathing in and out, in and out, in and out on this graph. So you just got that gentle TV. The TV is the tidal volume as you're breathing gently in and out. If you take a huge deep breath in, you fill the lungs, and you get right up to the total lung capacity. So you fill the lungs right up. And if you completely exhale everything you possibly can, you get down to about here, and you leave about 1.5 liters of air in your lungs, but you never completely expel all of the air in your lungs. There's still about 1 liter to 1.5 liters there. So that's just a very brief overview of the musical instrument that is the larynx. You require this energy source, which is the bow of a violin or the lungs of the voice. It requires something to vibrate and produce sound, which is the violin string or the vocal folds. And you require something to resonate. And in the larynx, that is the pharynx, the oral cavity, and the nasal cavity. And it's the interaction of the lungs and the pharynx and the resonators and the larynx that give every voice its individual quality. The pitch of the voice is altered by stretching the vocal folds to raise the pitch, and by shortening the vocal folds to make the pitch lower, and using the voice in a non-abusive way, and we'll talk about vocal abuse in subsequent lectures, relies on maintaining the voice as a hydrated instrument that you're not abusing. Yeah, it's my daughter again shouting. If you would like any further information, do have a look at my website. Follow me on Twitter if you wish. I will sign off there and say goodbye, but I will see you for subsequent lectures afterwards. Okay, bye-bye.